All right, so let's get started with uh, drug use in pregnancy and lactation. Once again, my resources are RxPrep and Pass Naplex Now. I always say both are excellent resources, and Lexapro, welcome. Both are excellent resources. Make sure you're paying attention to the key drugs guy, study tip gal, and anything that's bolded and underlined. If you feel one resource does not have enough on a subject, make sure you supplement it with your own sources. All right, so we have um, background and lifestyle management. Pregnancy is confirmed by a positive HCG lab result, which is human chorionic gonadotrophin. And in the first trimester is when embryo is most sensitive to teratogens. And so we really want to be careful. You may have heard when people are trying for pregnancy, they'll stop drinking, they'll stop smoking, or any other habits that may be harmful to the unborn child. And this is why. Some people, some patients, they are not trying or they're not sure. They become pregnant, and because of alcohol or smoking or any other medication use that can have an effect, it can cause issues prior to birth and after birth. So we want to be cognizant of that. We have to do dose or regimen changes during pregnancy. A good example is hypothyroidism. We have to increase the levothyroxine dose. Can anyone tell me a brand name in the chat of levothyroxine? All right, good. Starting to get some responses. Excellent. Next, we have the ACOG guidelines for safe and effective drug use. ACOG is the American College of Obstetricians and Gynecologists. And good job, everyone, on the responses. And they give guidelines for safe and effective drug use. Another thing that you need to know is the G and the P system. G stands for gravida, which means how many times the patient has been pregnant, and P is for para, which means how many times the patient has given birth. So, for example, if you see G2P2, that means the patient has been pregnant twice and has given birth twice. I mentioned earlier about behavioral interventions. Smoking cessation, alcohol cessation are important. All right. Next, we have vitamin mineral supplementation. A big one is folate, which is vitamin B9. This deficiency can cause neural tube defects. Can anyone tell me any of the two portions of our neuroanatomy that is a neural tube or that is developed from the neural tube? Okay, good. Starting to get some. I see brain and spine. Good, good. And those two are correct. Fast fingers, Wad. Good job. Or Wad. Next, we have the sources, orange juice, green leafy vegetable, dried beans, cereals, and fortified flour. And we're looking for 400 micrograms per day, which is the recommendation. And for normal adults, and 600 micrograms per day for pregnant patients. DFE stands for dietary folate equivalence. Next, pregnant women in the ages of 19 through 50 require 1,000 milligrams per day of calcium and vitamin D, 15 micrograms or 600 IU per day for development of both the mother and the child's skeleton. not just development, but also maintenance. Now, prenatal vitamins are prescription and over the counter. Our next slide is going to be pregnancy categories. The old system was A, B, C, D, and X, and there are updated categories. Problem is, a lot of people and a lot of places still use the old categories, so we'll cover them. And not necessarily a problem, but definitely a learning point. A, studies show no risk to fetus in first trimester. B, animal studies demonstrate no fetal risk. C, animal studies show harm where benefit outweigh the risk. A good example would be if someone has an infection and tetracyclines, it's sensitive, the organism is sensitive to tetracyclines. Are we going to risk uh, the teeth discoloration to prevent the infection or to cure the infection kind of thing? D, we have positive evidence of risk to fetus. However, the benefit outweighs the risk. This is a life-threatening condition. So, this is a more difficult choice, and I'm not going to scare anyone with any crazy examples. Last, we have category X, and this is the medication is contraindicated. The updated categories are divided into three. The first one is 8.1 pregnancy, and this covers the risk of developmental outcomes. Category 8.2 has to do with lactation, and this covers the drug or metabolites that are excreted in breast milk. And 8.3 are going to be females, males of reproductive potential, effects on fertility. All right. Next, we will start with drug treatment. And just for everyone's uh, info, if you are using RxPrep for this category, Mr. Turtle, welcome. For this category, the key drugs are in a study guide, and there's also a chart for different conditions, preferred management, and notes. If you're using past Naplex now, they have a pregnancy section, but they also have, excuse me, in the medications, they will have a pregnancy section. So just keep that in mind. Both are comprehensive and provide needed information. So we'll start with a condition, nausea, vomiting of first trimester. You counsel the patient, no large meals or spicy foods, small, frequent, bland diet. You can do vitamin B6, which is pyridoxine. Excuse the 8, I'll fix that. That is category A, and it can be IM or PO. Tony, welcome. We have diclegis, which is category A. This is delayed release 10 milligram doxylamine succinate and 10 milligrams pyridoxine hydrochloride. Now, this brand diclegis is very expensive, and you can do a workaround by prescribing or counseling the provider to do 10 milligram doxylamine succinate separately and 10 milligrams pyridoxine hydrochloride separately. Next, we have Bongesta ER or extended release. This is 20 milligrams doxylamine and 20 milligrams pyridoxine also. Over the counter, you can try Benadryl or Dramamine. However, both are category B. And then we have 5-HT3 inhibitors, and these are going to be second line therapy because they are category B. And you can use more carefully in the second and third trimester because use in the first trimester has been linked to congenital heart defects and cleft palate. Now, ondansetron or Zofran can prolong QT, as well as dolestron and granestron. All right. Next, we have constipation during pregnancy. Here, you can increase your fluid and fiber intake. Psyllium is a good example. Second line, you can try milk of magnesia. And third line are going to be senna and bisacodyl, which is Dulcolax. Those are category C. Another condition, UTI during pregnancy, macrobid is category B. It is contraindicated in near term or third trimester and during labor and delivery due to the possibility of hemolytic anemia. Keflex PO, if the patient is near term. Can anyone tell me the generic for Keflex, please? And the generic for Ansef. Excuse me. Ansef or ceftriaxone are IV treatment options for pyelo. Right, getting some answers coming in. And apologize for the voice and the cough. Seasonal allergies are doing me not so great. So, I see we have Vicky with some answers. Anyone else for Keflex or Ansef? Now, Bactrim and quinolones are category C, so we avoid those for the end. Good. Now, one thing I've mentioned in earlier sessions, if you are in this session and something is new to you or you're unsure of it, please make a note and go back and review it. If not today, tomorrow. It's a good way for you to strengthen your foundation base. All right. So, yes, cephalexin and cefazolin, very good. Now, third condition, pregnancy rhinitis. This is common. First choice is going to be saline nasal spray. This is category A. Antihistamines are category B. And nasal decongestants like Afrin or Neosynephrine are category C. Can anyone tell me answer either question? Any antihistamines that you can think of? I will accept generic and brand names. And then for the nasal decongestants, especially Afrin, which is over the counter, can you tell me what you counsel the patient in terms of timeline to use? All right. Right, very good. So I have some answers for antihistamines, getting some guidelines for OTC nasal decongestants. Okay, very good. We have not more than 48 hours, not more than 72 hours because of rebound. Both are correct. Very, very good. All right, let's continue to the next slide. Now we have lactation, pain, HIV, and contraindications. So starting with lactation, the AAP, which is going to be the American Academy of Pediatrics, recommends 6 months of exclusive breastfeeding as long as it's mutually desired by mother and child and there are not safety risks. So, if anyone has any exposure to this, sometimes the child issues with the child breastfeeding or issues with producing enough milk, there can be several reasons for this, and if it's not possible, then we supplement with formula. The newborn should receive 10 IU of vitamin D daily, and during the months of 4 to 6, they should also be supplemented with 1 milligrams per kilograms of iron. Newborns are born with about 4 months of stores of iron. The mother should increase caloric intake 4 to 500 kilocalories per day and continue the prenatal vitamins and omega-3 supplement. I've included a link to something called LactMed. And this is a library essentially where you can type in any medication or chemical compound, and it'll tell you whether it's excreted in breast milk and the risk to the child. Pain. Codeine and tramadol should be avoided. It is expressed in breast milk, and this can cause excessive sleepiness or breathing difficulty in infants, and it has unfortunately resulted in some cases of the child passing away. HIV. Breastfeeding is not recommended. ART or antiretroviral therapy should be initiated. One of the moderators, Suspicious Bunch, has an HIV guide. I plug this every time we do a session. Please look in the resources section and review it. It is extremely high yield, extremely comprehensive, and you will not be disappointed. Contraindications, chemotherapy, radioactive compounds, and then there's also a special section or technique called pump and dump, where you can use a breast pump to pump the breast milk, but dump it during the times when the drug concentration is going to be highest. So we're looking at amiodarone, lithium, statins, and metronidazole. There are a couple other examples. Can anyone tell me a brand name for metronidazole or metronidazole? And then also amiodarone, if I can get some brand names. Getting some answers, good. All right, getting some answers, good job. Now, we will start. I have three practice questions. Once again, this is a little condensed. Do remember that there is, for RX Prep, there is a study, a block and a chart for you to review. And in Past Naplex now, they are bolded or underlined. So let's start with practice question one. And if you're new to this session or this review, I'll read off the question. Please wait until the end of the reading and then go ahead and put your choice in or choices um, in the chat. If you're not sure, you're welcome to mention that it's a guess and or put a question mark next to it. Now, this is a select all that apply question, so remember it can be one answer, it can be all answers, or anything in between. Both Pass Naplex Now and RX Prep do a great job of not setting any patterns. The Naplex does not have any patterns in terms of how many it can be. So, AB is a 31-year-old female reporting to your clinic for a prenatal checkup. Her past medical history includes hypertension. She is planning to become pregnant in the next few months and wants to be placed on a medication regimen that is appropriate during pregnancy. Which of the following would be contraindicated for AB's hypertension during pregnancy? So, starting to get some answers. Did anyone else want to put their choices? Looks like we have a fairly fair consensus for the answers. All right, so everyone has chosen C and E, and everyone is correct. So great job. So we're talking about a special population that have very specific recommendations for drug therapy. And for example, warfarin is contraindicated, and we prefer heparin or low molecular weight heparin. So, choice A, choice D. Now remember, nifedamine and nifedipine, excuse me, has to be IR immediate release, and methyl dopa are the first line oral antihypertensives. Hydrochlorothiazide is recommended as third or second line, and that's HCTZ. So, both ACE and ARBs are contraindicated in pregnancy. There's a class-wide black box warning because of its effects on the RAAS, the renin-angiotensin system. So, they should also specifically not be used in the second or third trimester because they can cause injury or even death to the developing fetus. Anybody have any questions or concerns about practice question one? All right, so nobody has any questions. We'll continue. Good job, everyone. Now we have practice question two. A 33-year-old female has a history of hypertension, GERD, and depression. Current medications include Prilosec, Zestril, Tums as needed, and Zoloft. She just found out that she is pregnant. Which of the following medications should be discontinued immediately? Now, in addition to your answer, if you can put the generics for A, B, C, and D as well. See, some of you have answered. Let's test your generics, your brand generics. All right, waiting on the brands and generics, please. You see some answers. Good. All right, very good. So, has everyone chosen what made their choice? So, the choice is going to be A, and for Zestril or lisinopril. And this is due to the risk of for fetal abnormalities. In the second and third trimester, it can also cause fetal death. So the other medications are generally safe, and a couple of you chose D, and D is generally safe under supervision. Third trimester, there is an increased risk for pulmonary hypertension and possible withdrawal in the neonate. So we just have to keep that in mind. Good job, everyone. Good job. Anyone have any concerns about practice question two? All right, moving on to question three. And this is the last question. A patient RB is prescribed ondansetron to treat her severe nausea and vomiting. Which of the following is not true about ondansetron? A. It is a serotonin 5-HT3 receptor antagonist. Choice B. Constipation, dizziness, and headache are some side effects associated with its use. Choice C. Available forms are 1 mg tablets, 2 mg 10 ml oral solution, and transdermal patch. Choice D. It is pregnancy category B and can be used if the patient has hyperemesis associated with pregnancy. Good. Starting to see some answers. All right. So, anyone else want to have a go? All right, very good. So, choice C is the correct answer. It is not available in 1 mg tablets, 2 mg 10 ml oral solution, and transdermal patch. That is actually granisetron or Kitro. Ondansetron is available in oral film, IV injection, 4 mg and 8 mg tablets, ODT 4 mg and 8 mg. And just to clarify, ODT is oral dissolving tablets, and it's also available in 4 mg per 5 ml oral solution. So this is common in the Naplex. While choice C is factually true, it's not true for ondansetron, it's true for granisetron. So those of you that guessed, make sure you go back and review the available forms. Give Zofran a review, and and that's it. Now I'll open the floor to questions for the whole topic or any of the practice questions. So Nikki asks, we have to know all the dosage forms for each drug. For certain high yield medications, yes. Zofran is one of those. Zofran we use all day in and out, both in acute settings, chronic settings, inpatient, outpatient. So yes, Zofran is one of those. Good question. Also in the resources, while we're talking about brands and generics, there is a guide for top 200, top 300. I used to say 200, now I say 300 is important. You can break it down, the different, you don't have to do all 300 in one day. Try to do 10 or 20 a day. Try to do some association. If you've taken the medication, you helped a patient take it, you have a family member kind of thing that really helps. Good. So the question is, do we have to know the drug's pregnancy categories? Once again, for the high yield in RX Prep and um, past Naplex now, yes. I will share with you, for let's say you memorize all 300 of the brand names and generics, you don't need to know the pregnancy categories. This is more of a rule in versus a rule out situation. There, pregnancy medications that are allowed are limited, and so it's not as big as you think. For the majority, the answer is just going to be a no, or it's going to be a category D, and the Naplex is not going to be testing that. That's more of a real life or clinical situation. So knowing the few that are category A, or if a patient is pregnant and you're treating them for a condition like the ones we covered, pain, HIV, nausea, vomiting, there's only a handful that you really have to know for the Naplex. Good question. Any other questions or concerns that I can answer? Also, I haven't mentioned this before, or I'm not sure if I have, or if you're new. If you're in your Naplex prep, whether you're taking it for the first time or if you've taken it before, if you have a test results or assessment that you'd like me to go over with you and help you come up with a plan, feel free to send me a message. If you're going to send me if you've taken the Naplex before and you're sending it to me, make sure you either just send me the score part with the areas of competency or block out your personal info. Anyone have any other questions or concerns for this topic or in Naplex or MPJE in general? I'd be happy to answer them. And if not, we can end a little early today. Okay. So you're welcome, everyone. Got another affirmation for you. The affirmation for today is you are where you are supposed to be. Sometimes we don't see that. We want to be anywhere else sometimes, whether it's traveling financially, physically, mentally, emotionally. Just know that your time is coming. Put in the hard work, try your best, and you will get the result that you're looking for, if not today, tomorrow. All the best to you. Take care, everyone. Thank you. Oh, and don't forget to do the survey. Thanks.